Welcome, everyone. So glad to have you with us here today as we kick off another series of She Matters events. I am Marguerite Pierce. I am the co-founder and COO of She Matters, and I'm going to get things started and just remind you of a handful of housekeeping items, and I will pass the baton over to Jade. Um, so first and foremost, if you're joining us today and you'd like to be on camera, that's your choice. You can turn your camera on. I ask that everyone remain muted. I ask that those of you who have joined us who are not Black mothers to, during the Q&A session, yield the floor to Black mothers. This event and our series are curated specifically for that demographic and that audience, and we want to make sure that they have the opportunity to get the information that they need. There in the Zoom, one of the emails that you would have gotten is a text number you can text to should you need support if any part of this conversation is triggering to you. We're going to be talking about depression and anxiety. So we want to make sure that you remain supported if you are triggered by anything that anyone shares in this space. So be mindful of that. I'm going to copy and paste and post it in the chat so it's easily accessible. Lastly, we will have a Q&A kind of during the last 15 minutes of the session. And the best way for us to manage that is for folks that have questions to post them to me so that I can read them and address them to either Jade or Dr. Kauffman, who's joining us as our guest speaker today. So I think that's just the easiest way to do that. Is to put your questions in the chat, and then I'll go through them and we'll do our best to get through as many of the questions as possible. I don't think I've left anything out. So without further ado, I'd like to hand the floor over to the founder and CEO of She Matters, my best friend, Jade Kearney.
Hi, everyone. I am so happy you are here today. Give yourselves a round of applause for Saturday self-care, taking time out to focus on something that matters to you. She Matters, it means so much to me. And so for those of you who haven't been following us or who haven't been to our events, I just want to give you a little backstory on She Matters. 3 years ago, I was given the amazing task of being a little girl's mommy. My daughter's name is Kenora. And I was over prepared. I mean, I had the doula, I took the Lamaze classes, I took hypnobirthing, I had her Pampers ready, I had the clothes sized out in the closet, but I wasn't prepared mentally. I had struggled on and off with anxiety throughout my life, but I never thought about what is it going to be like with a baby. So at about 3 months postpartum, I really started to realize that something was wrong. And my postpartum anxiety showed itself in the form of something called intrusive thoughts. So I would have thoughts like, oh my God, what if I throw her out the window? Seriously, what if I throw her out the window? Or what if I accidentally smother her? Or what if I don't want to walk past the kitchen because I don't want to be near knives. Every day, my mind was haunted with these ruminating thoughts of things I might do to my child. I reached out to my family. I reached out to my aunt. Everybody said to me, hey, you'll be okay. Don't worry about it. This is normal. But 6 months in, I knew it wasn't normal. I knew something was wrong. I couldn't sleep. I couldn't focus. And I felt like I should be enjoying this in a different way. I didn't need to be a TV mom. Oh, this is so amazing. But I just needed to find some peace. So after reaching out to family and to no avail, I looked online and there were very, very few resources that spoke to Black women about postpartum anxiety and depression. I found chat rooms. That's how I even found out what I was experiencing was called intrusive thoughts. But none of the women in the chat rooms were Black. None of the psychiatrists or psychologists were even women. A lot of them were men. And I felt really alone. So one day I came across this BuzzFeed article, and it was called Postpartum Depression, Black Women Suffering in Silence. Changed my life. There were 10 stories of Black women who had experienced what I was experiencing. And what I realized at that moment was they were all better, right? So they all had gotten better. And I wanted to make sure that I got better, but I got better with a message as well. So that prompted me to start She Matters with my best friend and my fiance. So we started She Matters a couple years ago, and it was a brunch. It was a brunch in Newark, and it was just She Matters mental wellness for Black women, and it was sold out. From there, I knew that She Matters was bigger than just a brunch. It was a movement. It's a community, because so many of us experience anxiety and depression postpartum. Some of us have postpartum anxiety and depression, and it turns into like chronic depression and anxiety. And so I wanted to make sure that I was able to carry this community past just the brunch, and that's why we're here. The second part to why we're here is today, especially, is because I'm pregnant. I'm 5 months pregnant. And I tell everybody I was nervous about having another baby. I was extremely nervous. Marge, you might have to pin my video because I see you. Do you see me?
Yeah,
Okay.
we see you.
Okay. I was extremely nervous about having another baby because I didn't want to experience what I experienced. Even though I was on the other side of things, even though I felt better, I was better, I still felt like, oh my God, I'm on antidepressants now, and that worked for me, and I go to therapy and I'm so much better. But what if this happens again? So baby number 2 was a surprise, just like baby number 1. And I got really nervous, and I started talking to my psychiatrist and started talking to my therapist about, should I come off of my antidepressant? Spoke to family again, not the right avenue. Oh, you should be careful. You could harm the baby. What if you harm the baby? Your anxiety and depression can't be that bad that you would consider harming your baby. And after my message and after this widespread movement that we've started, I was still being shamed. So I went to a therapist, and my therapist said, well, it's up to you. If you want to stay on it, I know how to support you through that. If you're going to get off of it, I can support you through that. I went to my OBGYN. It's really up to you. You have to think about your health. What is going to benefit you? How do you feel? Then I went to my psychiatrist. Go back and ask your OBGYN. And I did this ping pong thing that was crazy. And finally, somebody told me to speak to a reproductive psychiatrist. I had no idea what a reproductive psychiatrist was. I was like, what is that? I'm already at the psychiatrist. I've been to the OBGYN. What is a reproductive psychiatrist? And I found out a reproductive psychiatrist does many things, but one thing they can do is help women who are pregnant talk about whether they want to be on antidepressants, whether they're going to breastfeed with antidepressants, and they kind of can guide you through that just hand in hand a little bit more than a psychiatrist. So our guest today is really going to talk to us about the experience of postpartum anxiety and depression, but also talking about postpartum anxiety and depression and medication. So Marge, if you want to go ahead and introduce Dr. Kaufmann.
Yes, and I mean, you introduced her, but Dr. Sarah Kaufmann, she's a reproductive psychiatrist, and she is in sunny San Diego, where the weather is probably just a little bit nicer than it is currently in New York. And she's going to walk us through, tell us a little bit about her background and walk us through exactly what it is that she does and how she treats patients. And then she'll be available for a Q&A session right after. So, Dr. Kaufmann.
Hi, thank you so much for that kind introduction. Before I even start to introduce myself, I just wanted to first of all validate Jade's experience. This is incredibly common, unfortunately. It's an experience a lot of women go through. And I'll talk a little bit about why that is. And I also like to start off at the beginning just with the disclaimer that while I'm a mother, I'm clearly not a Black mother. I've treated a lot of women of color, but I just, from the beginning, when I speak about, I'm going to speak generally about postpartum depression, anxiety, something we call PMADS, and about treatment, and just share a little bit of tidbits of things I've heard from some of my patients who are women of color, but I don't want to presume that is not who I am myself, and I have not exactly walked in the shoes of all of the Black mamas here. So just like to start with saying that. So a little bit about myself. I did my training at Columbia. So I lived in Washington Heights for the past 5 years until I moved to San Diego just a few months ago. There I did general psychiatry training, but I specialized mostly in reproductive psychiatry. I did a fellowship in that, which mostly involved treating women who are pregnant, postpartum, women struggling with infertility or fetal loss. And then I also stayed on for an additional year to do a forensic psychiatry fellowship because I am very interested actually in incarcerated women and mothers. And I worked at Bedford Hills, which is a maximum security prison about an hour outside of Manhattan. And they have a mother-baby unit there. So I have experience also kind of working with women who are involved in the criminal justice system and how that can affect their experience also of mothering. So that's a little bit about my background. Nowadays, I still work for the Department of Corrections in California. And then I also am the director of a maternal mental health program for a hospital system in Orange County. And then I have a private practice doing almost all reproductive psychiatry. And basically, like Jade already said, reproductive psychiatry is essentially a psychiatrist who has special expertise in working with women around not just pregnancy, it also can be around menopause and other areas of transition, but particularly around pregnancy and postpartum. So to start, I just want to normalize, and this is something, feel free to ask me questions about your own experiences at the end and share about your own experiences, but essentially the experience of what we call perinatal mood and anxiety disorders, or PMADS, are very common. And in general, for all women, there just can be a lot of shame around sharing their experience of feeling depressed or anxious or having intrusive thoughts, which are actually quite common in the postpartum periods. For dads too, actually, but particularly for moms. And there's a lot of shame in general. And I think, at least for the patients I've treated, there can be particularly a lot of shame within Black culture about expressing these type of these symptoms, or sort of the sense of you got to be a strong mom and get through it. And so I think for all moms, it can be hard to talk about these things, but depending on our own cultural or family backgrounds, it can be particularly hard to bring up these kind of symptoms or even recognize that they're symptoms. So the first thing I just want to share is that overall, 80% of women, so almost all women, experience the baby blues. And that's what probably most of us here have experienced, most of the moms here have experienced, which is this feeling usually that only lasts in the first week or two postpartum. This feeling of having trouble sleeping, being irritable, crying a lot, maybe not feeling quite like yourself. Those type of feelings, though, should resolve in the first 2 months postpartum, or first 2 weeks, postpartum, and should never rise to the level of not wanting to be around the baby. I mean, there's the normal, oh, I need a minute away from the baby, but I need to get I need a moment to, take a shower, if you can even get one in the first 10 days postpartum. But it shouldn't rise to the point of, I don't want to touch the baby, I don't want to be near my baby. I'm having thoughts of wanting to die. Those types of things are not normal. So I like to emphasize for women feeling not like yourself, feeling out of it, in those first few weeks. It's not that it's okay, but that's not a reason you necessarily have to go see a doctor or seek a higher level of care, unless it rises to the level of starting to think again about death or feeling like you can't spend time with your baby. And the reason why that women experience the baby blues, I sort of think of on a couple different levels. One, you go through this huge hormone shift, right? Your hormone levels are 100 times higher than they've ever been. So it's like PMS times 100. And it comes back down to essentially postmenopausal levels. So that causes a lot of changes in mood. Second, not only is a baby being born, but you're being born as a mother, and maybe as a mother for a second time or a third time. But this is a huge role change. It's a role change within the relationships you're in, familial relationships, friend relationships, the relationship you have with yourself and your own identity. So that's a huge shift. It's different than really almost any other shift we make in life. It's pretty sudden. You're you're becoming you're a mother as you're pregnant, but it's just different once that baby's here. And what does that mean? And so that can bring some changes in mood. And then third, most of us have experienced some forms of trauma in our lives, and especially if that trauma is related to childhood trauma or sexual trauma, birth and motherhood and breastfeeding can bring a lot of that stuff back up. And while it's a wonderful time, and motherhood and the beginning of motherhood can be a time to heal a lot of that past trauma and sort of imagine what things were like when we were children and what our own family structures were like, it can also bring up memories that some women haven't had in a long time, memories of things that have happened, and that can be challenging. So I sort of think of it as those three factors can lead to the baby blues. But then for a lot of women, so overall, we think about 25% of women, so 1 in 4. So a lot of women, maybe yourself listening to this right now, experience what we'd actually define as a perinatal mood or anxiety disorder, like major depressive disorder, generalized anxiety disorder, maybe even OCD, which can have those intrusive thoughts. And actually, women of color are thought to be affected. Maybe even up to 40% of women of color can experience a diagnosis of PMADS, which is almost double the rate. And we think that has to do with some of these larger implicit and explicit biases in our healthcare system, which is a bit beyond the scope today, but in under-identifying basically mental health treatment. As I'm sure you're all well aware, there are huge disparities just in maternal outcomes, not even talking about mental health, but maternal outcomes in terms of pregnancy and outcomes for baby and mom for women of color. So all of that we think starts to affect why these rates may be higher. And so when you think about that, that's a lot of women. It's a lot of women who wind up having these symptoms. So what type of symptoms are we talking about? So here I'm talking about not just these general mood changes sort of in the first few weeks, but persisting thoughts of feeling like I really can't spend time with my baby and attach with my baby. Thoughts of feeling like you might be better off dead. Really not being able to sleep when the baby sleeps. Of course, we can't really sleep with a newborn, but even when the baby's napping, feeling like we can't sleep. These chronic intrusive thoughts, which as I mentioned earlier, can be very common actually. These can occur in up to a third of women. In New York, I remember there, women will have the thought, oh, I'm gonna somehow throw the baby on the subway, or the baby's gonna push the baby into the subway by accident. And it's important to distinguish, these are not thoughts about actually wanting to harm a baby. It's the opposite, right? These are thoughts of being terrified that something might happen to our baby. But a lot of women, and especially women who maybe have had previous, maybe in their own childhood or previous engagement with, for instance, like Child Protective Services or other type of social service agencies, can be terrified to bring up these thoughts to their healthcare providers because they're scared. If I bring up the idea of something maybe happening to my baby, are they going to think I want to hurt my baby? Or is someone going to think kind of try and take my baby away? Are they going to, or not understand what's happening? So I think what Jade using that term intrusive thoughts, language is so important. So when women are having these type of thoughts, being able to go to your healthcare provider and say, I'm having intrusive thoughts. They're not thoughts I want to act on, but they're really bothering me. And because the outcome that we do worry about with these type of intrusive thoughts is it can lead moms to not want to pick up their baby, to not take the subway with their baby, to not, like in Jade's instance, like by the window, not to maybe go look out the window and get some fresh air, because these thoughts make us scared and we worry about things that we're engaging in being potentially harmful, even if they're not. And so these symptoms can be really common. Less common, but really important to kind of watch out for is if these symptoms are not treated, particularly depressive symptoms, women can go on to experience even what we call postpartum psychosis, where women actually are feeling so ill, they start to have delusional beliefs or think things are happening to them or maybe to their baby. And again, that's a bit beyond the scope of this talk, but the importance is just being attuned to these symptoms. If things don't feel right, going to talk to a provider, talking to family or friends that you feel would be supportive. I think all too often when women go to family and friends, they hear, like Jade's experience, oh, this is all just normal. But it's not normal for thoughts to go to the point that you can't get them out of your head. They're making it hard to engage with your baby. They're making it hard for you to get back to work, making it hard for you to do the things you want to do. And so it's important to be able to recognize that in ourselves and in our family and our friends and our community. I'm happy to answer more questions about that, but I want to get on to the medications. So that's a little bit the specific question of that why I was brought here today. So in general, what's unfortunate about mental health in general, but particularly perinatal mental health, is you can imagine if you went to see your doctor, like if this was in Jade's situation, if she had, gestational diabetes, let's say, And she went to go see her doctor, and they said, oh, we're worried about gestational diabetes and we need to treat you for the gestational diabetes. There's little discussion about, there's going to be a risk benefit discussion, but it's not, oh no, we're too worried about, hurting the baby. We're just not going to treat this. There's always this benefit of what can we do that makes sense for mom? What can we do that makes sense for baby? And there's not this stigma around if you take a medication that could potentially have a side effect. We just can't use it because you can see the potential benefit, right? Is to keep mom and baby safe. Unfortunately, when women have experienced something like postpartum depression or anxiety before, or for women who've never had a child and maybe they're starting to have symptoms, there often can be a lot of stigma around taking an antidepressant or an anti-anxiety medication. So I think it's important to try and find a practitioner. And if you can't access a reproductive psychiatrist, your OBGYN, your general psychiatrist, that is able to have a nuanced and personalized conversation for you and not put it all on sort of how Jade's experience was, well, how do you feel? And if you really think you need it, right? Because the reality is untreated depression and anxiety are not great for baby either. In the same way that if our sugars are really high because we have gestational diabetes, or if our blood pressure is really high because maybe we have gestational hypertension, those things are not great for mom or for baby. The same thing can happen if mom's feeling really depressed and anxious or having intrusive thoughts during pregnancy. Those can affect the child. And we have outcomes that show that if mom's not treated. Now, it doesn't mean mom needs to be treated necessarily with medication. It could be with therapy. It's with whatever works for mom. But it's important to recognize this isn't just about, I think a lot of women feel like I'll just shoulder through it. I'll just deal with these thoughts. I'll just deal with my anxiety. I just have to tough it out for my child. And well, in and of itself, I think a mom should feel empowered to not be feeling that way during pregnancy. It's hard. I mean, I know what it was like being pregnant. You don't want to take anything. You're terrified about what could happen to the child. But also it helps treat the baby. And for moms who already have kids, it can help treat the whole family too, right? Because if mom's not feeling well and mom's not doing well during pregnancy and postpartum, not only is that hard for the newborn, but that's hard for the rest of the family unit. So I'd like to think of when we're talking about risks and benefits of medication, it's not just, I think often gets focused on, or what are the possible risks to the newborn. That's in the consideration, of course, and that's in the equation to make the decision. But there's also how's mom, how's the rest of the family unit. And so the most common medication that's prescribed in general for women with depression or anxiety or even OCD, not psychosis, which we won't talk about today, but that's an antidepressant medication. So this is what you hear about most commonly, something like Zoloft or Prozac or Paxil. I don't know if any of those names are familiar to you, but these are called SSRIs, which stands for selective serotonin reuptake inhibitor. It's a big word. It basically just means these medications help a chemical in your brain, which is called serotonin, stay around in your brain for longer. We have little vacuums in our brain that suck up serotonin, and that's why it's called a reuptake inhibitor. They inhibit those vacuums. So it helps your own natural serotonin levels stay higher. And so that helps people just in general, and moms, to feel less depressed, less anxious, have less intrusive thoughts. So these medications, tens of thousands, if not hundreds of thousands of women have been on throughout pregnancy. Old studies that were done decades ago used to compare a woman who was on an SSRI, let's just say like Prozac, versus a woman who was on no medication. And in those original studies, there was some concern, it looks like maybe these medications might cause some birth defects, although it wasn't clear. Maybe could lead to some preterm labor, maybe baby's a little smaller, we're not so sure. And so because of those studies, there was sort of this worry about, are these medications safe? Since then, more recent studies are more nuanced and more accurate, and that they compare women with depression, right? So we're not just comparing your regular old woman who has nothing to do with depression, she's just on no medication for psychiatric reasons compared to someone on a psychiatric medication. We're comparing two women with similar diagnoses, one who chooses to take medication and one who does not, which is a much more accurate comparison. We now have two similar groups that we're comparing, which makes sense because the question isn't, for no reason am I going to take an antidepressant, it's I'm depressed. So we want to compare women with a similar underlying. We wouldn't take a woman without hypertension and give her a hypertensive medication in pregnancy and compare her to someone with that. So in those studies, there's been no evidence that there are increased risk of birth defects or outcomes of that sort in the first trimester. With one medication, Paxil, There were a few studies, again, these have now been disproven, showing maybe there could have been some cardiac effects. And so while that's since been disproven, you may find a lot of doctors still just steer away from Paxil. And so generally I tend not to prescribe it, even though it looks like it's okay now, and it doesn't look like it's still risky. If you go read about it and Google it, some women just feel too anxious about taking that medication. And there's plenty of other SSRIs that work. So it tends not to be the one I personally prescribe, but there's nothing necessarily wrong with it per se. Oh, did someone ask something? Oh, okay, sorry.
No, you're frozen for a second. It's okay now.
Okay. So that's the first trimester. Then in the second and third trimester, generally we think of these medications, we have never seen, and when we've done comparison studies, we haven't seen increased rates of miscarriage, increased rates of mom feeling more or less nauseous, for instance. In fact, some women find that they're a little less nauseous on SSRI because SSRIs can also be used to treat things like irritable bowel syndrome and some general GI symptoms. So sometimes women actually feel a little better. We don't really see any changes for mom or baby in that time. At the time of birth, so for women who have been on an antidepressant medication, and right now I'm talking about SSRIs, but this applies to other types too, again, beyond the scope of this talk, but if you've heard of things like Cymbalta or Effexor, those are SNRIs, those are commonly prescribed in pregnancy too. Wellbutrin, a few different caveats there, but that's another commonly prescribed medication in pregnancy. All of these medications, the idea is mom's been getting it. It's helping mom feel better. Some of that medication is going to baby, right? In the same way everything we eat and drink and do when we're pregnant goes to baby. So some of that's going to baby. So after baby's born, we do see that about a third of women, maybe not a third, a quarter to a third of women report that they think their baby was a little fussier than maybe their previous baby or than what they anticipated. And this is called neonatal adaptation syndrome. And we think of it as the baby kind of got used to having that medication, and now that it's gone, they're having sort of almost like what you think of as withdrawal. They're not in withdrawal in a serious way. This has never once in the literature been reported to lead to a serious outcome like a NICU stay or mortality, nothing like that. It's more just that baby can be a little fussier, maybe cries a little more, maybe doesn't take quite as long that first sleep that you first get and think, oh, I'm gonna sleep now that I'm a mom, and then doesn't really happen again. So maybe that's not quite as long. Okay, so that's what we do see happen. Again, it's more likely to not happen, but it does happen. It's a real possible side effect. It's a real possible risk. Most women and doctors decide, baby's a little fussier for a day or two compared to me feeling depressed and anxious throughout the pregnancy and how that's affecting me and baby. I'm okay with that. But for some women, that's like, no, I'm not okay with that. And that's ultimately why I think the most important thing is listening today and in the future is just getting all the knowledge you can and making the choice that's right for you and your family, because these things are nuanced and it comes down to how you feel about these things. One other thing I want to mention about in the immediate postpartum period, there is a rare thing that can happen in any birth. It's called persistent pulmonary hypertension of the newborn. This can happen, we think it happens in maybe 1 to 2 out of 1,000 births, unrelated to any medications. It just sometimes happens, just like sometimes birth defects can happen. So, or fetal anomalies. Anyway, so this 1 to 2 cases out of 1,000, so less than 1%, like 0.1%. Some studies have shown that might be raised to more like 2 to 3 out of 1,000. So a very rare thing that can happen may happen slightly more often in women who are on SSRIs. Again, when you Google this type of thing, you might see risk is doubled, and it sounds like, what? I have a 50% chance of this thing happening. That's not what that's saying. It's saying this really small chance of, and I'll talk about what this is in a moment, of persistent pulmonary hypertension may be slightly increased in women who have been on an antidepressant. So that is something to think about. Again, we still think of this risk as much, much less than 1%. It's only slightly increased. And in general, it's not something, we see commonly. This is serious, persistent pulmonary hypertension of the newborn. It can lead to breathing difficulties, and babies sometimes have to go to the NICU. So it's something, of course, you want to consider when you're making these decisions. But again, it's a very rare outcome. But I just like people to know that. And then finally, a lot of moms ask, well, what about these medications long-term? Like, I'm taking this medication. Is my baby gonna be depressed or anxious or need medication when they're a year, 3 years, 7 years, on and on? The good news is we now have studies of women that have been on antidepressant medication, 10 years out, 20 years out. And we've seen no dissociation for women that have been on antidepressants with changes in development, like intellectual development, motor development, autism, them having depression or anxiety, nothing like that. And again, that's because we now are comparing equal groups, right? Long ago, they would take a group of women who'd been on medication compared to women who had not been on any medication and go like, oh, maybe some of these kids do have higher rates of depression. But the reality is that's likely to, now that we've controlled and compared equal groups of women, that's probably more likely to be there is a genetic component to depression. There are environmental components to depression, and it's probably due, well, not probably, it's deemed to be due to that and not to medication itself. So we think of long-term, when we think long-term, how could these medications affect our children when they get older? We don't think they have a detrimental effect. And in fact, some studies have shown women that have had well-treated depression and anxiety, their children actually have better outcomes long-term, even if that treatment was with medication, because mom was better able to engage and attach with baby. Because you can imagine if you're a young mom or an older mom or any mom, but you're new to being a mom, and being a mom's new to you, and you're having intrusive thoughts, or you're crying and you can't get out of bed, those things are going to affect your ability to engage with your baby, and that's going to affect, you know, your mental health and the baby's mental health. So this was a lot of information. I would suggest is I'm going to answer whatever questions you may have. There are some really good websites, which I provided Jade and Marguerite ahead of time. So hopefully those will get sent out to you. But Postpartum Support International, which right now actually has a Black mother on the cover, which is wonderful. Because I think Jade's absolutely right. Lots of times when you look up this stuff, a lot of information, it's a lot of biases here. You look up information, there's a lot of white women and white babies, and it can feel like, how does this apply to me? And is this relevant for me? But anyway, Postpartum Support International has wonderful general resources about postpartum illness, peripartum, experiences and symptoms. They have a bunch of virtual free support groups that have just blossomed during COVID. And they have a particular one actually for Black moms that I've heard good things about. So that's one great resource. Another great resource for any type of medication, not just psychiatric medications, is called Mother to Baby. And on that website, you can look up mostly any medication. They don't have everything, but almost all medications. And it gives you really basic, pretty basics. You might want to go talk to your doctor for more details, but basic factual knowledge about what do we think about this medication in pregnancy, what are the risks, what are the benefits of the medications for everything, for antibiotics, for hypertensive medication, for psychiatric medications. And they have almost all their info sheets are also in Spanish, and they're working on getting them in other languages as well. So that's a really useful resource. And I think if it's the type of thing you're thinking about talking with your doctor about, bringing something like that printed off can be really helpful to show that you've already been thinking about it and to help you kind of frame your own specific questions about what you're wondering about for your risk and benefit analysis. And that's essentially, I wanted to leave ample time for questions because at the end of the day, these kind of discussions about medications are really specific to each individual, each family. And so I wanted to allow time if anyone had particular questions about particular medication or particular situations, or just in general about perinatal mental health. So thank you.
Thank you so much. Before we go into questions, I just wanted to add something to the group. I am in no way advocating for you to get on medication during pregnancy. I'm just telling you my experience. And if you follow She Matters, or if you're new to She Matters, you'll know that for me, this has been researched to the highest potential so that I can come to you guys with the information. Because what I've noticed through my postpartum mental health journey, whether it was baby one or now baby number two, is the confusion that I felt when I'm trying to make sure that my mental health is stable. Like, I can't get straight answers. There are no straight answers. And if we go to family, because of the stigma in Black culture, which most of us all know, right? Because of the stigma, we're not getting the support that we need. And then because of medical neglect, we're not receiving the support that we need. So for me, it was important that as I go through these different things and as I go through this journey, that I come to you guys with the information that I have. So I just want to just be 100% honest and frank. I am on a medication called Luvox because I have OCD. I did stop taking, sometimes they'll give you a medication for like if you have a anxiety attack. I did stop taking that, but I do take this medication and I feel comfortable. In the beginning, I did not. I really was shamed. I was shamed so much by family. And it really hurt me because I would never want anyone to think that I would do something selfishly. But I want us all the Black women on this call, to know that like taking care of yourself is not selfish. If you're not okay, if I got anything from Dr. Kauffman, if you're not okay, the baby's not going to be okay, right? So we have to make sure that we take care of ourselves. And I just wanted to put that out there. Like, if you guys have questions, we're going to open up for questions, but if you have specific questions for me and what I've experienced either after my first baby, who's 3 now, or now, please, I will be 100% honest, because if I can help you circumvent what I've gone through, I would love to do that.
Great. We have a question that came in, and this one is for you, Dr. Kaufman. Are you aware of any research related to PMAD and ancestral trauma or generational trauma, and pretty much like what's the synopsis of that research?
Yeah, so that's a great question. So we know that trauma lives through generations, right? This idea of intergenerational trauma, where not only do we inherit the genes from, the actual DNA from the people that came before us, but there's something called epigenetics, right? And that's this idea that when we've experienced trauma, when our mother experienced trauma, our grandmother, our great-grandmother experienced trauma, their genes could have literally changed. That's what epigenetics are. Parts of our genes can change in response to stress and to trauma, and that can get passed down through the generations. In addition to that, actually passing down, right, there's also the environmental factors that can lead to intergenerational trauma. So if we've experienced trauma, we may interact with our children in a different way. Our grandma may be interacting with us, and sorry to make it all mother-centric, that's kind of how I think, but our family interacted with us in a different way. The messages that we've gotten about what it means to be a woman, to be a mother, these things are also passed down. So they're actually passed down in our genes, and they're passed down in our environment. And so there has been research showing that mostly all kinds of trauma, particularly trauma, as I mentioned before, that occurs in childhood, or messages were kind of given as a child, do increase our risk for basically postpartum and perinatal, mama brain here, perinatal mood and anxiety disorders. So, but the beautiful thing, as I kind of alluded to earlier, is a lot of research is now being done on what type of healing can be done for intergenerational trauma and ancestral trauma. What can we do now, looking back, honoring the people who came before and the trauma that was there, and how can we integrate that for ourselves? And one of the areas of research that some people I've worked out with Columbia were starting to look at was, how can we think of childbirth and the birth of a mother as being a time of healing, of saying these are things that happened before, and now these are the ways I want to honor that, and ways I want to change how things happened in the past. And it's a very fragile time, but it's a beautiful time in that, as we know, our bodies completely change in this time, right? And so why not think maybe we can, our mind and maybe even some of our DNA can change a bit in this time, and how we're kind of processing what's happening. So it's kind of a long answer to what you asked, but definitely trauma increases risk. But we're also trying to think of this time more and more as, how can we use this as a malleable teaching time to try and heal for future generations? Let me know if you have more questions. That's a big topic.
Yeah, no.
Can I piggyback off of that? I just wanted to say that my experience with trauma is, I have 2 parents who are drug abusers. My father was in prison most of my childhood. My mother has struggled with drug abuse my whole life, and her mother struggled with alcoholism. So it was definitely passed on to me in my OCD, now that I think back. And after all of my therapy, I realized that my OCD was kind of like inherited, right? My grandmother was very anxious and scared about death and health. That went on to my mom, and I started to experience that very early in life. I never made the connection that this might be why I'm so scared when I had my daughter, but through therapy, I definitely realized that my childhood had a lot to do with the fears and anxieties that I had in raising my daughter.
Yeah, great. Thanks, Jay. Thanks, Dr. Kaufman. Another question for you, Dr. Kaufman. How long after birth can anxiety or depression be considered postpartum? My last child is 18 months, but I'm still feeling anxious and having depressive moods.
That's a great question. So I think there's sort of three different pieces to this. One, classically, we think of postpartum depression, anxiety as a year postpartum. That said, there's more research coming out, and depending on who you talk to and what their philosophy is, we think this period probably extends quite a bit farther because, like I talked about, while that initial hormone shift has already happened, there's still all of these changes in our role, right? As the child gets older, we're having to kind of reassess, constantly. That's what we do as moms. We're constantly retooling, readjusting. Maybe at 18 months, I don't know your exact experience. I'm happy to talk more, but sometimes if whether or not we've started or stopped breastfeeding can also lead to a big change in mood. Often women who maybe only experience some postpartum depression at the cessation of breastfeeding that can worsen or actually have a new episode because there's a large hormonal shift there as well. Often around 18 months or 2 years, maybe thinking about having her next child, and that may have hormonal changes and often have changes in terms of just her thoughts again about her role. And then finally, there's something about our brains literally change after we have a baby. There are parts of the brain, like in terms of short-term memory and what actually maybe have a little more challenges, which is baby brain is a real thing. Like that's actually it is real. And we think part of that's all of the hormones during pregnancy, and part of it's the sleep deprivation. But then there are part of our brains that grow, and it's incredible. The parts about empathy and multitasking actually grow and are strengthened during pregnancy and postpartum. And so in the same way as our brains are literally changing, which we can see on imaging in studies, the way in which maybe we feel depressed or anxious might be different. I see women who on one medication or maybe never needed medication before they're pregnant, and after, things are just a little different. Like their brain's working a little bit different. They might need a different medication. Maybe they need to start for the first time. Maybe they need to switch up the way in which they're engaging with therapy. So even though if someone's having first symptoms around 18 months and you want to go to see someone, they might not define it as postpartum depression, mood, anxiety disorder. It's still very much maybe related to the changes that have happened postpartum. And I see a lot of women that are 2, 3. I see a lot of women, it all happens again around perimenopause, all throughout the spectrum. I mean, everything kind of blends together. But to answer your question strictly, it may not be considered postpartum depression depending on who you're talking to, but of course it's related. It's related to the baby and the subsequent your subsequent path.
No, I think that makes a lot of sense. Thank you. I'm going to ask a question here, which maybe some other people might have. In terms of considering going on an antidepressant, are there things like should you exhaust, like therapy, cognitive behavioral therapy? Like, should you exhaust that and then be like, oh man, I'm not feeling better and I've done, this for 3 months? Or is it, can you say, you know what, this is really bad. Therapy's not my thing. Maybe I should just look into getting on something. Like, what does that progression look like?
Yeah, absolutely. And so I think this is different for every woman depending on their own preferences and style. But overall, I kind of go by how the woman's functioning and feeling. If she says, you know what, I want to give therapy a little bit more of a try, I want to try a different type of therapy, and let's wait and see. But honestly, the best bang for your buck is a combo, therapy plus medication. And so if we have someone we're trying to get to feel better quickly, if the symptoms are pretty bad, or even if the symptoms aren't too bad, but maybe you've had a prior episode and you're worried it'll come back. The downside to a lot of these psychiatric medications, well, they work really well. A lot of them take a couple months to really reach full efficacy. So often I just counsel women, ultimately it's your choice, it's your body, it's your mind. But if you're already feeling not great and we're waiting to see, that's time that we could be getting this in your system and helping you feel better. Because it's really that month postpartum where things can get really, really dark and really scary and really hard for a lot of moms. And if we hadn't started something already in preparation, then we'll start. And often knowing something has started, and there's some meds that kick in a little faster to help with sleep and anxiety. I think maybe Jade was alluding to that, something like Ativan that can help you temporarily get some sleep. We can do that, but a lot of the antidepressants won't kick in. So I usually counsel, if it's bad enough, you're really not functioning, and or if you're worried it's going to get there in the next few months, again, I leave the decision to the woman and we make the decision together, but it usually makes sense to start, is what I would say.
And I just want to add to that, just so from experience, I gave myself until my daughter's first birthday. And I specifically said this to Marge. I said, if I am not feeling better, and I was in therapy for 9 months, talked to my therapist about it. If I'm not feeling better by her first birthday, then I'm going to seriously consider medication, because I can't suffer anymore. Like, I'm literally suffering. And the reason why I'm not trying to get on medication is because I feel shame about it. Not because, and I was scared. I mean, I think this is something that most of us have experienced as Black people in general. We do not trust mental health care providers. We don't trust medical medical physician in general. We just don't trust medication, especially anything for your mind. Like, is it going to control us? Are we going to be different? And those were all the thoughts that I had. Am I going to be a different person? Am I not going to act like myself? All of these things. And so I waited 1 year, but looking back, I wish I didn't, because that was a year full of suffering for me. And I was getting better gradually with exposure therapies, especially like to things like the knives and things like that. So I was growing, but I was still suffering. I got a question here, Marge. Any suggestions for new moms during COVID? Whew. I will say this. I am a pregnant mom during COVID, and I was just diagnosed with COVID. So I don't have a new baby, but I'm going to tell you my experience, and maybe Dr. Kauffman can just piggyback off of what I'm saying. It's really difficult. We're stuck in our houses. We may be stuck with our kids. You don't have the space that you may need to like fill yourself, because everybody is around you. Everybody's stuck around you. So what I do is I chant. Like I have a practice where I chant, meditate, really, and have a support system. And that's why we created She Matters. So if you're feeling like a little stuffy, you're feeling like you need to get away, you're feeling like you need to scream, a community is extremely important. And I don't mean your mom, your aunts, your cousins. Not that my mom, aunt, and cousins are not extremely supportive. It's just that sometimes they're gonna go based on what their lives are. They're gonna give you experiences based on what they've done. If you come to a group where women are talking about being, being stressed or being anxious or depressed during COVID without judgment, it may help you make some decisions that make you more comfortable during the time. So, Dr. Kauffman, what do you think?
I absolutely agree. I think it's very hard for us to find our community right now, and community is so important in pregnancy and postpartum, and having that support, and it looks different now. And so if that community is online, if it's people you can socially distance with in some way, which I know is so challenging with babies in particular, but really seeking out the help when you need it. And I agree with Jade, maybe not just with mom and sisters and friends, but looking for an online community like this exact community right here, or the support I mentioned earlier with Postpartum Support International. And I will say, we do have evidence coming out that not only is COVID incredibly stressful and isolating in and of itself, but rates of depression and anxiety are rising. And so while that's a negative thing, the good news is there's more and more access to healthcare. Mental health care is opening up. Many therapists, I'd say that, especially if most of you are in the New York area, the East Coast area, most therapists have moved online. Most psychiatrists have moved online. In my private practice, I see everyone online. At Hoag, I see almost everyone. So I probably see, I've seen at this point hundreds of moms during COVID, right? Postpartum and pregnant. And there's always something to be anxious and worried about in pregnancy. It's always going to be there. And it's an unprecedented time right now. So I would say reaching out for care if you can. There is more access than there used to be. And also online community. I absolutely agree. And then if you can, kind of echoing what Jade said, if you can find at least some sort of space. I remember back when we were in Washington Heights in a tiny little spot, I literally, for me, that was the bathroom. I mean, I don't know how it is for all of you, but some space, even just for 10 minutes, just light a candle, or read a book, or meditate, or whatever, take a shower, just some space that you can sometimes take for yourself, which I think is so hard right now, where we are literally around the same people all the time, can be really valuable. And just letting family know, the same way I would have maybe went for a walk before, like I need to just kind of step out into the other room. But I feel for all of you. I mean, this is a really hard time. to be dealing with all this.
And thank you so much, Dr. Kauffman. Are there any other questions?
I see one down here that was addressed to me. Can I answer that one?
Yeah,
Or
sure.
I see one asking about what would be a good postpartum medication, a particularly good medication in pregnancy, as I was mentioning earlier, ones that I wouldn't prescribe. So my first comment to that is whatever medicine works for you. The best medicine, with few caveats, if you're someone who's been on a medication before and it works, that's usually my number one go-to. Unless, I mean, there's a few psychiatric medications like Depakote, for instance, that we usually try pretty hard to try and move it to a different type of medication. But overall, almost any of the antidepressant, anti-anxiety medications, if that's what works for you, that's what I would go with. If you're someone that you haven't been on one before or you're not sure, personally, I think Zoloft is a great choice because most women tolerate it pretty well. They don't tend to have too many of the, most SRIs, they do have sexual side effects, unfortunately, not for all women, but for some women. But Zoloft, some women don't experience quite as much sexual side effects. And by that, for women, I mean sometimes more difficulty with orgasm or loss of libido or lessen libido. And also a little bit less of the GI, like nausea, vomiting. Also, Zoloft is virtually undetectable in breast milk. So a lot of women like the idea, I'm going to get on something now, and this is something I'm not going to worry about in breastfeeding. I didn't really mention breastfeeding earlier. Most of our medications we consider, again, I don't like the word safe because everything has risks and benefits, right? But we consider generally safe in breastfeeding. But if you came to me, never been on a med, you're feeling depressed, anxious, having OCD-like thoughts, I might say, let's try Zoloft first. If there was no reason to try anything else, just because it's an easy medication to start. But really, if something's worked for you, that's the best. Because what happens a lot here is we'll get the idea of, oh, let's choose the most safe medication, but it doesn't really work that well for mom. And so now mom's getting exposed to a medication and she's still not really treated, right? So what we want to do is treat mom, right? Because then we eliminate the risk to mom and the suffering for mom and help baby, and we have the medication. So what works for you, if nothing, maybe Zoloft. That's kind of a short answer, but the more specific questions, that's what I would usually do.
Okay, great. Thank you. I have another question that just came in for you, Dr. Kauffman. Have there been any research on the potential mental health benefits of encapsulating your placenta?
So there's a lot of, this is very popular now. I will say a lot of people ask me about it. Personally, the scientist in me, I'm not entirely sure how, when you take a placenta and after it's been prepared, right, usually it's essentially not necessarily burned, but some equivalent of cooked or processed. Serotonin, the idea is the placenta is full of hormones, it's full of blood, it's full of nutrients. This is animals eat their placenta to give them nutrients, right? So maybe we should do the same thing. I think the scientist in me, I'm not sure what the science is behind that supports it for us, in that by the time you process the placenta, all those hormones would have been denaturalized, which essentially means the proteins and stuff are not what they were. So in my opinion, the evidence is low that any of the hormones and chemicals that we would think we're going to get benefit from the placenta are going to benefit us. That said, some women swear by it. If it's something that you're excited about and interested in, I know like my doula in particular was really into it. It's not something I decided to do for myself. My doula kept being like, are you sure? Like, I think it's great. I don't think I don't really see the evidence. I'm vegan. I'm like, I don't know if I want to be eating my placenta, but so that's what I would say. So I'd say do what feels right for you. I think there's some nice ideas behind it, but I think that the evidence behind it is a little bit weak and how much it may help.
Can I just piggyback off of that? So I didn't do it with Bean, but because I felt like the hormonal crash, I feel like it's been something that I've been considering. But I also want to tell all the Black women on this call, this is not an African tradition. And this is something that really irritates me when it's like, oh, I'm doing this, and it's like cultural. So in Africa, on the continent of Africa, and the countries within Africa, they bury the placenta. And it's usually a ceremony to say that you are a part of the land. So I want to do it to maybe it'll help with me losing all the progesterone during birth. but I just want to make sure women, because I did not know this. At first I was like, oh my God, this is like getting back to my roots, girl. This is like the motherland. No, it's not. No, I was in the motherland and they were like, you're doing what with the placenta? That sounds insane. So it is not, it's not something that they do on the continent, but it is something that I've heard of. And my doula did it, and we've been talking about it for the new one. It is something that I'm considering. So maybe one of our next conversations will be with doulas and about the benefits as well. But thank you so much, Dr. Kauffman, for adding that, because I've been on the fence about that as well. Do you have any other questions there, Marge?
No, I think, and just in time to wrap this up, do you or Dr. Kauffman, did anyone chat you additional questions? Let's just make sure there's nothing else hanging out.
I think that was the only private one I got. I didn't even realize it was. I'm still figuring this stuff out.
Okay, yeah, no, I know. Like, there's like 5 different parts of Zoom that I'm keeping track of here.
I think, can I just say something really quick before we wrap up? So I just want to thank Dr. Kauffman for being here. I want to thank you so much for giving information. I want to thank you for being so open about being in a space for Black women, and you saying up front, hey, I know I'm not a Black woman, but I'm here to help. And so for everyone on the call, when I bring people on to our events, they are vetted. They are people who we trust. They are people who care about Black women. If we can't find a Black woman, we're going to find a woman. You probably will not see too many men here. So I am so thankful for you being here and giving your time and helping with questions. And for everybody who made it here today, this is part of your self-care, right? All of this is part of your self-care, and it doesn't stop here. And Marge will add, will give you some more information about that, but you can always privately chat me on my Instagram at JadeZen. You can chat us on our Instagram at shematters.io. You can add your name to the mailing list on shematters.io. And soon you'll all get an email about our app that'll be out next week. You'll get a download through your email. Dr. Kauffman, do you want to add anything?
Thanks so much for including me. I always like to give that caveat. I'm sorry if it comes off awkward at the beginning. I just like to be clear, you know?
Yeah, thank you so much. Thank you. Thanks
for all your questions. The more you ask, knowledge is power, you know? Just feel empowered.
Thank you.
Thank you so
Bye,
much.
Dr. Kauffman.
So just a little, some things to expect after today. There's an email that's going to be sent out. It's going to include, information on how to stay in touch with us on Instagram, as well as our next event, which is scheduled for December 5th. So right after Thanksgiving, where we're going to be talking about faith and mental health. I know this is going to be a biggie, and how we can reconcile the two and have the two work in our favor. So you don't want to miss that. There's going to be an email that's sent to everybody that participated in today's call at around 5:30, and it's going to include a link to register for that event, and that one is also free. So please, if you liked this one, spread the word about the next one. And we're cooking up something good for the top of the year. So hold on to your hats. It's going to be called She Wins. And it's basically an accountability and encouragement group. 2020 was unpredictable, and it threw us all for a loop. And I feel like everybody at some point during the year felt like they lost control. So for 2021, we want to use that as an opportunity to regain and reclaim some of that control. And that's what we're going to be doing with She Wins. And we want to be able to hold another one accountable and pretty much get shit done. Pardon my language, but that's what it's about. So stay tuned for information about that in the coming weeks. So thank you so much.
I'm going to plug, you don't see me in one right now because my stomach is humongous. But we have She Matters t-shirts, She Matters hats, She Matters sweaters on our website. You'll probably see them more often. You'll probably see Marge and I wearing them. just to say that like we're part of a community, right? Like we all matter. You matter, she matters, right? So if you're interested in any of that, you can go to shematters.io. In addition to that, I want to say, please, 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 please take care of yourselves over this COVID holiday. Again, we are here. If you email us, if you tag us, or if you private DM us on Instagram or Twitter or whatever, all of the things, we're there. So just because this event is over doesn't mean we're gone. And in terms of our next event, mental health and faith, my grandmother's a pastor. And when I told her that I was having intrusive thoughts, she told me to go to church and pray. And while I am all about faith and prayer, I knew that I needed more. And so one of my best friends, Dr. Colette Shefton, is she going by Shefton Poole Boykin?
Poole Boykin.
Doctor, this is her married name, y'all. Dr. Colette Poole Boykin is going to come on and talk, because she is definitely a church girl, but she's a psychiatrist, and she's going to talk to us about her perspective on faith and mental health. So again, thank you guys so much. Thank you, thank you, thank you. Please continue to follow us, and shout out if you need anything.
All right. Thanks so much, everyone.
Bye.
Enjoy. Happy Thanksgiving.
Thank you.
Thanksgiving. Thanks.